Hi, everyone. Welcome to today's virtual rounds. My name is Karan Kumar. I'm a third-year medical student at Toro College of Osteopathic Medicine. It's here in Middletown, New York. Um, so, as you guys know, we're going to kind of be going through um, today with the case. It's going to be a little bit of what we've done in the past. We'll start kind of in the ER and then move on to more of a surgery-centered case. So we'll go ahead and get started. Are you guys able to hear me? If you guys can just throw it in the chat box, yes. Perfect. And you guys are able to see my screen? Okay, great. So we're gonna go ahead and get started. Feel free at any point throughout the session, if you guys have a question, just feel free to unmute your mics and just ask the question. I don't mind if I get interrupted. I like it. I like to have a nice interactive session. We'll kind of go through a little bit of the outline of how today is going to run. It's similar to the past cases that we've done in the past. So we'll go through a case. I'll do a full presentation for everyone. We'll go through different sections of physical exam, differential diagnoses that we should kind of, the main ones that we should kind of at this level be aware of, the assessment and plan, and then we'll briefly go over some pathology of the disease. So for you guys, like I mentioned, just try and be as active as you can. It'll make it a lot more interesting if we have some participation. And make sure while you're going through this, have your SOAP note open up. So just make sure that note is open up. And if anyone's concerned or asking what a SOAP note is, so SOAPs is an acronym for subjective, objective, assessment, and plan. This is basically how every medical document is written in a hospital setting. So within like electronic medical record systems, everything's documented in this manner. So I've kind of made it a little bit easier for you guys in case you aren't familiar with this already. So if you look up in the top left corner of the slides, it should give you an idea for you to see where in the section of your SOAP note you should be documenting the information that I put on the slide. If you don't have that open or if you don't have access to it, just let us know in the chat and we'll fix that for you as we go through. The case details, like I mentioned, I've kind of put up here, it's for the subjective section of that SOAP note that we're talking about. So this again, we're talking just in the ER right now. We have a 45-year-old female with a past medical history of hypertension, hypercholesterolemia. She's presenting with complaints of abdominal pain for the past 3 days with associated nausea. She states the pain is diffuse but increased in the upper abdomen. She notes that is markedly worse after eating dinner last night. The pain is described as being sharp, waxing and waning, and improved with rest. The pain is stated to be at a 10 out of 10 at its worst and 5 out of 10 at rest. She states that she had about 4 episodes of this pain in the past, but cannot recall a specific diagnosis that was given. Additionally notes that she started having a dull aching pain in her right shoulder and mid-back, and she's currently status post a total abdominal hysterectomy that happened 1 year ago, and she is not a smoker. She drinks alcohol. She does not smoke, drink alcohol, or use any drugs. So does anyone have any ideas of what some of your differentials could be based off of just the information we have here? Again, you can feel free to unmute your mic if you want, or you can go ahead and just throw it into the chat if you'd like. And to help you guys out a little bit more in terms of what's important for this, I went ahead and just highlighted some of the more important information. All right, so some of the stuff that we're getting: stomach ulcer, gallbladder obstruction. All right, good. So here are some of the major differentials that appendicitis maybe. Yep. So here's kind of a chart that I like to think of when I'm thinking of these differentials in my head, specifically for abdominal pain. So if we're talking things like the right upper quadrant, I think of something with the liver or with the gallbladder, like some of you guys have mentioned already. If we talk about the left upper quadrant, I think of the stomach, the spleen. The right lower quadrant typically is appendix, and the left lower quadrant, I think of something to do with the large intestine, sigmoid, and rectum at sometimes. Again, these presentations can be very different. So in our patient here, we just got a very vague description of the symptom as being in the upper quadrants. So that could be right upper or left upper. And that's where kind of it comes down to us figuring out exactly what it is that's causing this pain that she's having. But in general, this is kind of my starting point when I think of someone's coming in with abdominal pain, where do we go next? So the differential diagnosis list for this patient, again, you can put a lot of things on this because she is very vague with her symptoms. We don't have a physical exam yet to kind of hone us into what we're looking at. But these are some of the bigger ones that you'll see a lot when you're going through medicine, when you're learning the GI system. So the first one, someone mentioned it in the chat, gallbladder obstruction, cholecystitis, possibly could be a result due to a gallbladder obstruction. We have pancreatitis as well, appendicitis, pyelonephritis, renal stones, and then acute cholangitis. So does anyone know, where would you get pain if you're talking about someone who has pancreatitis?
I'm gonna guess from the name pancreas.
Okay, yeah. So where would you think that a patient would describe the pain? If they're experiencing, let's say they have pancreatitis, where on their abdomen might you think that they might have that pain? So we have upper abdomen, left upper quadrant, left abdomen. Yeah, so in the upper abdomen, basically epigastric region is kind of where the pancreatitis pain would be. And then you might even have people that experience back pain with pancreatitis. So when you go through anatomy, and if you've gone through anatomy right now in college, you've probably learned that the pancreas is a retroperitoneal organ. And so partially retroperitoneal, the tail of the pancreas isn't retroperitoneal. And so when you get pain from pancreatitis, people with pancreatic pain will actually also have back pain, but typically we'll start with epigastric pain. Appendicitis, does anyone know where that pain would be? Okay, yep. In the chat, we got right lower quadrant, right lower side. Good, good, good. Does anyone know what pyelonephritis is? Okay, so we're close. Yes, it has to do with the kidney. Yep, there we go. So Maddie got it right. Kidney infection. So pyelonephritis is a kidney infection. And does anyone know where you would have pain that's kind of referred to pyelonephritis? Where someone would they may not experience this pain right away, but yes, we got the right answer. It's back pain, exactly. And then acute, I'm sorry, skipped renal stone. So this is basically a kidney stone. So kidney stones, the presentation of a kidney stone is a little bit different. You actually will get referred pain into the groins, into the groin region. Does anyone know why that is? So a kidney stone is basically a stone that is within the ureters of the kidney. But patients that have the pain that's associated with these typically experience pain that's like a sharp pain, but it radiates into the groin. Why would it radiate into the groin? So if any of you guys have taken anatomy already, you might remember, so the ureters will start at the kidney, the renal pelvis, and then they travel down into the bladder, and they actually will insert into the bladder. So that's why you get that referred pain, and that travels right into the groin. It's because of sometimes the stone itself is passing through. And again, we won't go too far in depth into this, but there are 3 specific regions of the ureter that get very narrow. And so patients with kidney stones will typically feel pain, not when the stone is just moving itself in the ureter, but specifically when the stone reaches these narrowing points that kind of cause the irritation of the ureter. And then that's when you get the pain into the groin. And then we have acute cholangitis. Does anyone know what this is? I don't expect anyone to know it. I didn't know it before I got to med school. But does anyone know what this is? Okay, so gallbladder infection is something we got, liver. So gallbladder infection would actually be the number one, but you're not far off. It has to do with the gallbladder, potentially, with the liver as well. So acute cholangitis is it's an infection of the biliary tree, and it's pretty severe as well. And it could be caused by an obstruction. It can be caused by malfunction of a sphincter. Um, but there are very telltale signs of what acute cholangitis would be. Um, and so those are the main differentials that I would kind of look at here. So we'll move on now into the physical exam. So if you guys have noticed, we're now in the objective portion of that SOAP note that we were talking about. So the number one thing, and I'm sure everyone has a different way of kind of approaching how they assess a patient. For me, the first thing that I'll look at, obviously, I'll get my history from the patients. I'll look to see any prior history that they have. But the main thing when I'm looking at physical exam is their vitals. That's the number one thing that I go to. The vitals will tell you a lot about the patient before you've even put your hands on the patient to assess them physically. Um, so here we are with our patient. So vitals, the heart rate is 110. So we got some tachycardia. We got BP is 155/90. Respiratory rate is 14. O2 stat is 98 on room air, which is RA. And then the temperature is 100.6. So does anyone know what classifies a temperature? What anything above this specific number is what we consider a temperature. Do you guys know what that number is? Yep, so we got a few people answering correct in the chat. 100.4 is what we consider a temperature. So anything 100.4 and above is significant for the temperature. So in the rest of our physical exam, we have an obese female resting in bed, appears her stated age. She's got no scleral icterus. Pupils are equal, round, and reactive to light, and her extraocular movements are intact. We'll go back to some of these terms once I get through the whole physical exam. So if you don't know a specific term, just hold on to it right now. And if I don't cover it when we go back over it, then feel free to ask. Cardiovascular, she's tachycardic, but regular rhythm without murmurs, rubs, or gallops. She got 2+ radial and 2+ dorsalis pedis pulses. Her lungs are clear to auscultation bilaterally without wheezes, rails, or rhonchi. Abdomen is soft, non-distended. Right upper quadrant is tender to palpation with a positive Murphy sign. Minimal tenderness to palpation diffusely. No CVA tenderness. She has a negative psoas and an obturator sign and no signs of jaundice. And her skin is normal with no skin tenting. So let's just go back to some of these terms that you guys might not know. Does anyone know what scleral icterus is? I'll give you a hint. It has to do with the eyes.
Can you say the word again, please?
Sure, scleral icterus. Okay.
Is it the white part of the eye?
Yeah, so we're talking about that white part of the eye. Specifically, we're looking to see if it's yellowing. So if we say that the whites of our eyes are yellow, or in the terminology that we use on the chart, if I said that this person had scleral icterus, what's something that would kind of pop up in your mind? What can cause, okay, good. Yeah, we got stuff in the jaundice, exactly. Jaundice, liver failure, good. So in our patient, remember, it's still significant that we look for that because we want to make sure if we're thinking we have something to do with the gallbladder and the liver, it's upper abdominal pain. We want to make sure that that's still something that we look at. Having it being negative is very significant for us as a clinician to figure out, do I need to move something or add something to my differential list or not? So we got tachycardic. Clear to auscultation just means listening to with a stethoscope. So if we jump down into the abdominal exam, so obviously our abdominal exam in this patient is going to be the most important thing that we look at. We're going to look at a few different things in the abdominal exam. So saying that the abdomen is soft and non-distended. So when we say that, we mean that we don't see any obvious bulging of the abdomen. So bulging of the abdomen could occur for a number of different reasons. Someone who is a chronic alcoholic would have a distended abdomen. They may just live with a distended abdomen. However, someone who's also, let's say, has a bowel perforation may also have a distended abdomen. It won't be soft, um, but it would be distended. So this next thing, right upper quadrant tenderness with a positive Murphy's sign. Has anyone heard of Murphy's sign before? So basically what Murphy's sign is, it's a very sensitive test for gallbladder pathology, specifically cholecystitis. And so the way that this test is done is it's during a physical exam. And so what'll end up happening is a physician will basically palpate under the right costal margin. And it's a deep palpation that they do. And they'll ask the patient while they're palpating to take a deep breath in. We say it's a positive Murphy sign when if the patient is taking a deep breath in, they have to stop in the middle because of the pain. A negative Murphy sign would be a patient who's able to fully breathe in and breathe out without having to stop midway. So for us, that's a pretty significant finding. CVA tenderness in this case, so CVA has two different meanings in terms of the abbreviations. When you're talking about it in a physical exam, it stands for costovertebral angle. If you're talking about it in, let's say, like a history, it could be a cerebrovascular accident. So just be mindful when you read CVA. Obviously, you'll have context clues to look at to see exactly what they're talking about. In this case, we're talking about costovertebral angle tenderness. What that is basically pain in like the flank, so the lower back area, which what we talked about earlier. Does anyone remember what that lower back pain could be associated with? What things that we had on our differential? So it could be anything to do with like renal pathology. So and also pancreas. Yes, you are correct. Um, so the pyelonephritis and also kidney stones. And then we also note down here negative psoas and obturator sign. Does anyone know what those are? Okay, so someone said muscles. Yes, that is correct. Psoas is a muscle. The obturator is a muscle as well. You have obturator internus and externus. So the significance of psoas sign and obturator sign is for its indication with appendicitis. And so what ends up happening if, again, going back to the anatomy of it, in the right lower quadrant, the appendix can sit in a number of different positions. Most common is retrocecally behind the cecum. And so what ends up happening at times is if you ask the person to basically contract their psoas muscle, which the psoas muscle is significant for allowing for flexion at the hip joint. So simply asking the patient to, when they're laying flat on the bed to lift up their right leg. And if you were to basically apply pressure against them lifting it up. So if you were to ask them to lift their right leg and you applied pressure down on their leg, that would cause the psoas muscle to contract. And if they feel pain, it's not as sensitive as a Murphy sign for cholecystitis, but if you do find it, your suspicion for appendicitis will increase because if you think about it, appendicitis is inflammation and infection of the appendix, which means surrounding tissue will also be inflamed. And if you have a muscle contracting underneath the appendix and it's irritating it, you're going to feel that pain in that moment. Obturator sign, it's the same general concept, but the motion is a little bit different. I'll be completely honest, I've probably seen most people do psoas sign a lot more than I've seen obturator, but it's a good learning point to know both of them. There is also another very specific sign for appendicitis. Does anyone know what it is? So there's two more if I'm going to be specific. So I've said psoas sign, I've said obturator sign. Heel drop test, nope. Anyone else have any other guesses? Pain around the belly button, that is very true. I'll talk about that in a little bit why we get that with appendicitis. So the first one that I'm thinking of is Rovsving sign. So Rovsving sign is basically, it's a little, it's not intuitive to think about why it happens, but what ends up happening is when a physician palpates the left lower quadrant and then they stop palpating, so they release their pressure, that's when the patient will feel pain in the right lower quadrant. So that's called Vrosving sign. And that's because of peritoneal, that's because of visceral irritation and inflammation. So that pain is being caused when you release and the peritoneum actually relaxes on top. And then the next one, which is probably the most important one, is McBurney's point tenderness. So when you have McBurney's point tenderness, this is basically a specific point on the abdomen. It's about 2/3 inches away from the right ASIS. So if you feel where your hip is right now, that bony protuberance that you feel right at the top of where what we would call our hip, that's our ASIS. So between that ASIS and your belly button, 2/3 of the way there, if you have pain in that point, it's called McBurney's point tenderness. Again, that's also significant for appendicitis. And then also we noted that that our patient did not have any signs of jaundice on the abdominal exam, and the skin was normal with no skin tenting. What would someone that has skin tenting tell you? If you saw if it said that this person had skin tenting, does anyone know what's the importance of that? Yep, good, dehydration. So if you have someone whose skin starts to tent, you basically just pinch the skin for a little bit, let go, and see how quickly it retracts down into its normal position. If it does tent, then you can say that that person is probably dehydrated. So again, we're still within our orders. The objective section in the orders now. So I've have a little hint up in the top there. I don't expect obviously anyone to know what normal values are right now. I've highlighted in red or changed the font color to red for the lab values that are specifically important for our patient, but being in the color red does not mean that they're high or low. I've put an H or an L next to the values that are actually high or low. However, what is in red is going to be important, not just for what we need for our patient, but also for our differential. So in this case, I'm going to just be talking about those values that are in red, and we'll talk about why they're important. So having a white blood cell count of 12, which is high, is important to us because of what reason? Having high white blood cells tells us what? Good, that the person has an infection. Perfect. The next thing that we're going to go over to is we're going to talk about bilirubin. So there are two different types of bilirubin that we'll look at, and then there's a total bilirubin. So in our patient, all three values are normal. And the reasoning why this is important is a little bit, I would say, I mean, just because I didn't know it beforehand, I'll actually open it up. Does anyone know why bilirubin and looking at the difference between direct and indirect is important? If you don't, I'll just explain it though. Yes, so it has to do with liver function, absolutely. So this will tell us the functionality of the liver, and if there's any obstruction in the biliary tree. So that includes like the hepatic bile duct, the cystic duct, and the common bile duct. If there's any obstruction in there, you will see a difference in your bilirubin. Specifically, you'll see that difference in the conjugated bilirubin. But eventually, if it's something that's progressing for a while, you'll see both bilirubin and you'll see both indirect and direct bilirubin increase. Then we have, I'll skip to go to AST and ALT. Does anyone know what those are? So it has to do the same thing with liver function. So if you've ever heard the expression LFTs, so the hepatic panel is looking at liver function in total, and your LFTs are your AST and your ALT for the most part. And now the next thing that's under here is alkaline phosphatase. So this is a specific enzyme that you'll see elevated in cases where there's obstruction of the common bile duct. So the epithelial lining of the common bile duct you'll start to see secretion. That's where alkaline phosphatase comes from. And so when you have infection and irritation of that common bile duct, that's where you'll start to see increase in alkaline phosphatase. Again, remember, I'm not saying these because they're high in our patient. It's just significant because going back to the way that we the way that we think and the way that kind of medicine works is we have our differential, and now we need to figure out off of our differential what's significant. So these lab values are telling us what's significant and what's not. And then we have amylase and lipase that are both within normal limits. Does anyone know what amylase and lipase is significant for? What disease process it would help us kind of hone in on? Yeah, good. The pancreas. So we're looking at the pancreas right here when we're saying amylase and lipase. Specifically, we look at lipase. And then we've also ordered a right upper quadrant ultrasound. Um, why did we choose to order a right upper quadrant ultrasound? Does anyone know? So based off of our physical exam and our orders that we've gone through so far, um, on our differential list, what do you think is, if we need, let's go back to that slide. So on our differential list, again, the order of our differential list is also important. Typically, the way that it's ordered is ordered from most important to least important, or most suspicious to least suspicious. So based off of what we've talked about so far, do we need to change the order of our differential diagnosis list right now? So based off of what we've seen so far, I personally don't think that it needs to be changed. We could probably move our number one suspicion should probably still say number one again because of that positive Murphy sign that we had. Pancreatitis, we could probably move down to a lower on our differential because we got the amylase and lipase back. However, you'll learn when you go through your clinical rotations, if you have a high suspicion still for a disease process, but your labs are telling you otherwise, and you have no other reasoning for why the patient is experiencing what they're experiencing, you still keep those diseases on your differential. In our case, though, I would probably move down pancreatitis. I'd move down appendicitis as well. Pyelonephritis, I would still keep probably as number two. Same thing with renal stones. And acute cholangitis, I would probably leave at the lower end because um, our patient isn't really experiencing very high fevers, a high white blood cell count, or any of those things that will kind of clue us into acute cholangitis, especially she's also not jaundiced. So in the ER, again, remember, we're all in the ER still. We're reviewing the past chart. We find out that the patient was actually diagnosed with cholelithiasis 5 months ago in the ED. And she was given follow-up with a surgeon, but upon further questioning with the patient, she denied ever following up with the surgeon. And so we decided to put in a surgery consult as well. Does anyone know what cholelithiasis is? Yeah, bile stones or gallbladder stones. Good, good. So what I would generally say, so if you're on a surgery rotation or if you're on an ER rotation, it's very site specific on when they will actually consult surgery in terms of, do they wait for imaging to come back or do they consult surgery before imaging comes back? In this case, we already know, we have a known diagnosis of cholelithiasis. She's had 4 episodes of this in the past. And so the likelihood that this is probably also the same type of episode happening is very high. And so consulting surgery at this point isn't a bad idea before waiting for imaging to come back. Of course, it takes time for people to come into the ER to see your patient. So in the meantime, we come up with our assessment and plan. So again, this is that A and P of your SOAP note, So number one, based off of just her history, we're saying that this is acute calculus cholecystitis. So what that basically means, acute, it's new onset. Calculus is that it's a stone causing cholecystitis. And remember, we're not just going to say in this instant that it's acute, like, or that we're going to just say cholelithiasis, because our patient did have a fever. Patient was tachycardic. And so she was showing signs of infection. Of course, we'll know for sure once the imaging comes back. We'll write on here, right upper quadrant, ultrasound is pending, surgery consult, NPO, basically meaning that we're not giving our patient anything by mouth, including food or water. antiemetics, so anti-nausea medication, and pain control as she needs. Does anyone know why we keep a patient, why in this case we're deciding not to feed our patient or give them anything by mouth? Yeah, for anesthesia. Good, good, good. In case you need surgery. Yep, for anesthesia. So this is a PIM question that I got asked early on when I did surgery. Does anyone know what's the reasoning? Why don't we like to feed patients if they're getting anesthesia? Again, I was asked this question on my rotation, so I don't expect. Yeah, but you guys got it. Potential for aspiration, absolutely. So even if they do aspirate, obviously the hope is that they don't when you're putting a tube for intubation. But yes, it's for that potential that they may aspirate. Good. And then their hypertension, it's controlled, continue their home meds. And their hyperlipidemia, same thing, controlled and continue their home meds. So while we're waiting for surgery to come on by, we get the imaging of the right upper quadrant. So I will explain this. There are some very telltale signs of what you see here, but is there anyone that wants to give a shot of what we're looking at? Again, you don't have to be right. Ultrasounds are hard to read. It's a learning experience. So if you want to give it a shot, go. Feel free to unmute your mic or write out what you think you're looking at, and then I'll kind of explain it. Okay, so we have someone saying 2 stones in the gallbladder. All right. So you are right with that. I don't know if I can say 2 stones specifically, but yes, there's definitely stones here. So what we're looking at here is the gallbladder. Are you guys able to see the cursor of my mouse? Okay, good. So here's a gallbladder right here. And what we're looking at around the gallbladder, does anyone know what this is? It's an organ. I'll tell you guys that. Around the gallbladder. Yes, the liver. Good. Oops. So we're looking at the liver here. Around the gallbladder, here's our gallbladder itself, the wall of the gallbladder. Here's the inside of the gallbladder. Again, the gallbladder's function, does anyone know what the function of the gallbladder is specifically? Yeah, good. Store bile. Exactly. So it stores bile that the liver makes when it's needed for digestion. So within this gallbladder, we see these 2 objects here. And then we keep looking past the objects and we see this change in color past the objects. So what we're looking at, like someone mentioned earlier, these are stones. And what we're seeing here, if we look lower down in the image, this discoloration is called shadowing. So this is a classic sign that gallstones will show. They'll show shadowing on an ultrasound. Now, the thing is why we do an ultrasound versus any other test is because gallstones are only radio opaque in about 20% of patients, which means, so radio opaque meaning that they'll be picked up by X-ray, CAT scan, things like that. And so the best modality to see gallstones would be an ultrasound because we'll be able to see them if they're radio opaque or not. Does anyone know how an ultrasound works at all? It's a confusing test, but it has a lot of good benefits to it. So basically what ends up happening, if you've ever seen an ultrasound being done, is you have sound waves that are actually traveling through the probe that they place on a patient. And then it travels through that gel medium that they use as well before they actually try and look for anything. And so the sound waves travel through this patient's skin. And what we actually see is the reflection of them. So the sound waves will travel in, they'll hit off the surface and they'll go back into the probe. And then we see basically we see the sound waves that returned. And we get hyper and hypoechoices that happen. And so when we look here on an ultrasound, air should be black, or fluid levels should be black, I should say, not typically air. And then we can see soft tissue as well very well. The one drawback of ultrasounds is that the image is only as good as the person who's doing the test. And so you'll find that a lot of people will, they're not easy to do, but ultrasounds they can be very specific. but because of the high user error that's there, they could be a little bit tricky. So when we're looking at this gallbladder, we see the stones here. The other things that we'll look for when we talk about cholecystitis is sometimes we'll see gallbladder wall thickening. So this wall here would be thickened. Sometimes you'll also be able to see some sludge. So like when I say sludge, that's basically bile that's been it's starting to conjugate enough into a stone, but it's not really at a stone stage yet. So it's kind of, if you want to think of the way that I think of it, it's bile that's really thickened up. And normally you'll see sludge here at this. So this is the gallbladder going into the cystic duct. If we had more of this image to follow through, it would turn into the cystic duct over here. And we can sometimes see sludge here. The other thing that happens with infections is that we get inflammation. With inflammation, we'll get edema. So we'll get swelling. So sometimes you'll also be able to see, maybe you can see it a little bit here where we kind of have a separation at the gallbladder wall. But it's very pronounced in some patients that have more severe cholecystitis. In the case of, you'll see this wall and then you'll see an empty space and then you'll see another wall. So that's edema surrounding your gallbladder. But in this case, main takeaways for this is we have the stone here and we see shadowing, so we can say that these are gallstones that are dense enough to cause these shadows to occur. Any questions on the ultrasound at all? Okay. So now the surgery team comes in, they see the patient, they talk to the patient, and they decide the patient's a candidate for an elective cholecystectomy, given history of her stones in the past, with this being her 4th case of symptomatic cholecystitis. She has a history of hysterectomy back in 2009, and she plans, and the plan for them is to take her to the OR today. So does anyone know what are some important questions from, we've now stepped out of the realm of ER, we're now on the surgery team. When you're on the surgery team, what are some questions that you think might be important to ask this patient? Good. Any reactions to anesthesia? Definitely. Anything else? If you've had any other surgeries before? Yep. Why would you want to ask that question? So why would you want to ask if the patient's had any surgeries in the past? Yes, in case there is scar tissue, absolutely. Does anyone know specifically what that scar tissue is called? In the abdomen, when we're talking about it, at least. Yep, good job, Lucy. Adhesions. So anyone who's had prior surgeries before is prone to getting adhesions, and that's just, it happens because the body's normal healing processes. The issue with the adhesions is that you can't see them on any image. You won't be able to see them on a CAT scan. You won't be able to see them on an X-ray or ultrasound, and so it makes it difficult when you're actually performing a surgery. It doesn't mean that the patient's not a candidate for the surgery. It just puts it that much more in the surgeon's mind of what they're going to encounter when they get into the OR. What are some other questions you might want to ask this patient who you now know you're taking to surgery with your team? Does she take blood thinners? Absolutely. Yep. And then I always like to, whenever I'm going on for a surgery consult, I'll always confirm with the patient if they're a smoker or not, regardless if it's written in the note or not. And the reason for this is because patients who are smokers have prolonged healing time. And so they're known to have more of an increased risk for complications. And so it's always good to know if your patient is a smoker for post-operative care. And that can also change some of the things that you do within the surgery in terms of medications and things like that. But mainly it's for that post-operative surgical healing that you want to know if they're smokers or not. All right. I will give a full disclosure. If anyone does not want to see a video, I'm going to be showing a video of a laparoscopic cholecystectomy. If you don't want to see it, just, I guess, minimize the screen. You'll hear me talk. I'm going to talk through the video itself. But if you don't want to see the gory details, then you can go ahead and minimize your screen now. Are you guys able to see the video screen still? Okay, perfect. So I'm going to go ahead and play the video. I will pause it in between and kind of explain what's going on. There is no sound, so don't worry if you can't hear the video. There's nothing playing, and I haven't muted anyway. So this is basically kind of like what our patient had: repetitive biliary colics, no previous history. In our case, the patient did have 4 episodes of this. Ultrasound showing cholelithiasis, and then they're doing a lap chole. So more or less, this is basically what our patient is also presenting with. So what they're going to first start off with showing is going to be what we call port placement. So for Give me 1 second, guys. There we go. So what they're showing here is where they place the ports. So a laparoscopic procedure isn't a procedure where they'll just cut into the skin. They place ports in specific areas depending upon where you're going to be doing the surgery. And what surgery you're doing dictates where these ports get placed. Obviously, it's for exposure and things like that. This is just a general placement of ports. And as you see here, what they're showing, that first thing that they showed, it's called a varus needle. So this is something that's very common in laparoscopic procedures that you'll see. You have to insufflate the abdomen. So if you think about it, someone's abdomen isn't going, we talked about distended abdomens before. We kind of synthetically distend the abdomen when you're doing a laparoscopic procedure. The reason being is if we have air in the abdomen, it provides more room for the instruments to move around and more room for there to be visibility of exactly what you're doing. Another PIM question or something you guys might want to remember, the air that's used to actually insufflate the abdomen is actually CO2. So here you see the ports are being placed in those areas that were shown earlier. And now what they're doing is they're retracting back the gallbladder. A lot of what surgery is all about retraction, tension, and visibility. So we have the liver here, we have the gallbladder here. What this instrument is doing is it's burning or using a cautery to basically take off the omentum that's attached to the gallbladder. And eventually what they'll be doing is they'll be dissecting through the hepatoduodenal ligament. Again, the anatomy of what they're going through at this stage, if you know it, that's great. But again, it's not something that you need to be too concerned about. So we had a question, why CO2? The reason for that is this instrument right here. So if you were to use oxygen in this setting, this is actually electricity that's going in there. And if you take a look, it'll actually start sparking a little bit as well. So O2 is very flammable. And that's why they use CO2 as opposed to O2. And so we'll go through this. So what was mentioned there was something called Cowlitz triangle. Does anyone know what Cowlitz triangle is at all? Again, that's not something, again, I expect anyone to know. So basically what it is, it's an anatomical triangle that you can identify certain structures. So what makes up the triangle, and you won't be able to see it in this surgery particularly because they use a different view, which we'll mention a little bit later. So again, this is just all dissecting off that omentum. But Cowlitz triangle is basically a triangle that makes up the free edge of the liver. Then you have the cystic duct, and you have the hepatic duct. And so that's a triangle that you'll see. And then running through the triangle is the cystic artery. So that's why that Cowlitz triangle is important. But like I mentioned, in this approach, they don't use Cowlitz triangle. They use something that we call the critical view. And once we get to that, I'll show you. So I'm going to just fast forward this. Basically what they're doing now is they started their dissection to get the gallbladder off the liver bed. As you can see, it's attached to the liver itself. So they're dissecting that out so that they can further get some traction. And obviously they need to remove the gallbladder. And so they need to actually dissect through there as well. So what you can see here is now they're forming and they're trying to look for their main structures. So one of the biggest things that you need to be careful when you're doing a surgery such as this is bile duct injuries. So specifically common bile duct. I mean, because we're taking out the gallbladder, so cystic duct injuries aren't so detrimental. However, if you can take it out without injuring it, it's obviously good. It gives you a better view. But a common bile duct injury is very, very bad. If you if you have if you injure the common bile duct, it needs to be repaired in that surgery. It cannot wait. So it's considered a surgical emergency. So we had a question, did you say the cystic arteries? And then yes, it transverses the triangle. So we're going through here. Again, they're looking for those structures that they want to see. Here's a gallbladder here. They're holding it at, you can call that either the fundus or the neck, the fundus or the neck of the gallbladder is where they're kind of pulling back. And remember what I said, surgery, this tool, the cautery doesn't work if there's not tension on the tissues. So here's that critical view that we talked about. So here we have our cystic duct. So if we follow this up, it should be going to our gallbladder, which it is. And here's a cystic artery here. So Cowlitt's triangle, we don't see the hepatic duct back here, but if the hepatic duct was here, the triangle that you'd be looking at is, here's one side, the hepatic duct would be back here, and then the free edge of the liver back here is your third side. And so transversing through that is your cystic artery. And so what they're doing now is they're basically applying clips to both the duct and the artery. Cystic duct, remember, cystic duct only. That's the only thing that they'll clip off. The common bile duct and hepatic bile duct will stay as is. And then they will apply the same clips to the cystic artery. This is actually a very common thing that you'll see. It's a standard procedure. Many surgeons follow it. You might see differences of how people practice, but typically you do 2 staples on the proximal end and 1 staple on the distal end. The reason being, I'll show you when we get to it actually, instead of jumping the gun. Now they're cutting that cystic duct here. And does anyone know how can we tell that this is a duct and it's not just tissue or omentum that we're cutting? Does anyone know how you can tell? So the easiest way is once you cut, you take a look and you see a lumen right there. And then you should be able to see a lumen there, just the view is distorted here. But that's how you know that that would be your duct. And then cystic artery, same thing, you can do the same thing. Sometimes it's not that easy to see the actual cystic artery. So if you're not sure if you've cut the cystic artery or not, you can take a look to see if you see the lumens there. So now they're continuing their dissection through to remove the gallbladder off the liver bed itself. So we'll keep going through this. And you can see it's, does anyone know why it's a fairly bloodless procedure once you get into the abdomen? So this cautery that they're using is actually coagulating the blood as it's cutting through these tissues, which is why you won't see blood when you're doing these procedures, as long as you're in the right plane. So in this surgery, they're in the right plane here. You can see that they're not charring the tissue that much. It's not burning. It's not turning black. And so again, you'll hear people refer to like seeing the plane or the fascial planes. Takes time. I still don't see them most of the time. And when you ask someone to show you like where's the plane, they're just like, the answer I've gotten more likely than not is always you just have to have practice with it. So there's that. So what they did now is they removed the gallbladder. They parked it, it's what we call it. They parked it up in the right upper quadrant so they can now go through and look at all the structures, make sure there's no bleeding that they can see. And then now they're going to remove the gallbladder. So they actually removed the gallbladder through one of the ports. So in this case, the surgery, they put the biggest port near the umbilicus, which is typically in a laparoscopic procedure where it goes. So they placed it in this little bag, they close it up. They removed all so trocars are the ports. So these things are called trocars. They removed all those things, or the ones that they didn't need anymore, because they had 4 in place. And now they're only using 3. Again, they're looking to make sure there's no bleeding, no leakage, and removing those trocars. And then they remove the gallbladder right there at the end. So that's the gallbladder. They've stitched up our patient. So again, remember there was four port sites. or trocar sites. And we see 1, 2, 3, and 4. The umbilicus is right here. And that's the end of the surgery. So we have some questions. Let me just go back to them real quick. Is it possible to remove the stones without removing the whole gallbladder? No. So if you think about it, there are modalities that you can use in terms of, so there was another question on here about using shockwave therapy for gallstone removal versus surgery. The surgical standard right now is to use surgery for that, because the presence of gallstones, having gallstones once in your life, puts you at risk for continually to have them over and over again. And the reason you're having gallstones is because that bile is sitting around and it becomes conjugated to other structures that's actually causing the stone. So there's a number of different reasons that can happen, and we'll talk a little about specific reasons later. But like cholesterol, cholesterol can cause stones. Having high cholesterol can cause those stones from forming. Having something that can cause anemia. So like lysing of your red blood cells, that increase in bilirubin can cause bilirubin stones that will be in the gallbladder as well. And so could you do a less invasive procedure to just, let's say, like break up the stones so that they pass through the gallbladder? Yes, I'm sure it can be done. And it has been done with sound waves, or like if you know anything about renal stones, like they use lithotripsy, which is sound wave to break up the stone. However, the likelihood of it reoccurring again is still pretty high. And the only way to get rid of gallstones is to remove the gallbladder itself. Any other questions about the specific surgery that we just saw before we move on? Okay. Do they take the CO2 back out? Very, very good question. So typically what will end up happening is once you've removed the gallbladder and you're finished with the procedure, the the air will start to leak out of the trocar site. So if you still have the ports in the areas of where they were placed, it's still a passageway for the abdomen. So typically what I've seen done and what I've seen surgeons do is before they take out all of the ports, they'll actually just push down slightly on the patient's abdomen to get as much air out as they can. However, the body will reabsorb the air that's there within 3 to 5 days. However, someone who has a laparoscopic procedure, does anyone know what's one common post-op symptom that they might have because of this pain? Well, I kind of have to answer away. Because of the air that we put in, pain under the ribs. Yep. So where else can that pain be felt? So if we're saying pain under the ribs, this is like, again, this is a stretch. I don't expect anyone to know this. If you do, that's amazing. Does anyone know what's the innervation of the diaphragm? So the diaphragm has this nerve innervation by the phrenic nerve. And the phrenic nerve will have referred pain to the shoulders. And so patients will typically, if let's say we didn't remove a lot of air after we took the gallbladder out, or if sometimes in a rush, surgeons forget to kind of do that a little bit. But again, as you're taking the trocars out, they start leaking the air anyway. But they may have shoulder pain. So that's another thing that I actually missed when we were talking about this. In the history, she started complaining of shoulder pain as well. And the theory is, and the reasoning why she experienced shoulder pain before the surgery when she first came in is the same thing. It's because the gallbladder, its proximity to the diaphragm, and you have referred phrenic pain, phrenic nerve pain, which will give you the shoulder pain that people sometimes experience. Yep. Back pain is also common with this as well. Yeah. So what's one thing, again, since we've now ventured into the surgery team, let's say we have a patient, completely separate patient, had a laparoscopic procedure done and is now complaining of increased bloating sensation, shoulder pain, back pain, and we've determined that this most likely is because of the air we've put into her abdomen or his abdomen. What's one thing that you think you can tell the patient to do that will probably help the body reabsorb that air quicker? So pass gas isn't a bad, it's not a bad guess, but remember, we didn't put the air into their intestines, right? We just put it into the abdomen. So passing gas typically it's not gonna help with that. Yes, if they actually had gas pain because they had increased gas in the intestinal system, I agree. Telling them to do that will do that. Walking around, yeah, that's the answer. So having them walk around, movement, is the number one thing that can help with that pain. Good job. So here's just a. It looks very convoluted in a surgery to see everything that we're looking at. But here's the anatomy of what we saw. So here's the cystic duct, the gallbladder. So what they were holding originally and kind of pulling back was the area right here. Here's our common bile duct. So when we talk about biliary tree, or someone refers to the biliary tree, they're talking about these structures here. So you have your right and left hepatic duct, comes down into the extrahepatic duct, or the common hepatic duct. Then you have the cystic duct, which will join with the extrahepatic bile duct and form your common bile duct. A lot of terminology. And then that will actually go into the intestine, specifically into the duodenum, and that's where the bile will be released. So does anyone know why our patient specifically noted increased pain after eating dinner last night? Why did that happen? Does anyone know? That's also very classic for cholecystitis or cholelithiasis. So what ends up happening is when we eat fatty food, yeah, exactly. Fatty foods trigger the release of bile. Our body makes bile because it needs it in order to absorb fats. And so what ends up happening is when we eat, there's an enzyme that's released. It's called CCK, and CCK will actually cause the gallbladder to contract. And so if you think about it, if we have stones that are sitting right here, and then all of a sudden we eat something and the gallbladder is contracting, it's trying to remove, or not remove, release bile into the cystic duct, but it's obstructed right here. And so that's why classically there'll be pain from that. All right, good. Any questions on that anatomy? Just like a picture of it before I go to a cadaver picture. Okay, so here's a cadaver picture of the same stuff that we were looking at. It's labeled as well. So we have our gallbladder up here. The liver is here. We have the hepatic ducts that are here. I'm sorry, cystic duct is here. The common bile duct is back here. And then it also has some arteries that are labeled. The gastroduodenal artery, the portal vein is back here, common hepatic artery is back here, and left hepatic artery. And the bile itself is green. They don't, in a cadaver, there's nothing that they can use to dye the bile green, but this is actually what it looks like. So in the surgery that we did, thankfully didn't puncture into the gallbladder. If we had done that, it's not a big deal. If that happens, it just adds on to some steps that need to be done in the surgery itself. Because we're removing the whole gallbladder anyway, puncturing or if we accidentally burn through the gallbladder wall, the worst thing that happens is that bile leaks out of the gallbladder while we're doing our surgery, and it just kind of distorts our view. However, what ends up happening in that point then is they'll put in irrigation and suction, and they'll clean up their view while they're going through. And then before they close the patient, they'll, like they did in the surgery we saw, they park the gallbladder up in the right upper quadrant, and then they'll just wash out really, really well. And a few times until they continue washing and they see clear water saline going in and clear saline coming out. But you'll see at that point too, like bile is green. Any questions on that before we kind of start going through the pathology? Any questions on the case presentation? So there's a question that came in. Someone said they shattered in a bariatric center and they mentioned patients undergoing medical weight loss are more likely to need a cholecystectomy. Is there a reason obesity has an effect on chances of getting gallstones? Yes, so obesity itself is a risk factor for gallstones. And it has to do with hyperlipidemia and the diet that they're eating. So having a fatty diet, it puts you at risk for getting gallstones. Hope that kind of answers your question. Any other questions before we kind of move on to the pathology? All right. So again, acute calculus cholecystitis. So the definition is acute, or the classification, acute right upper quadrant pain with fever and leukocytosis in the setting of gallstones. Leukocytosis is just a fancy word to say increased white blood cells. The risk factors for this, so we kind of talked about one a little bit. So this is classically the 4 Fs. So if once you start studying for your boards, they call it the 4 Fs. So female, fat, 40, and fertile. Having any of those 4 puts you at more of a risk for gallstones. Like we mentioned just now, hyperlipidemia and having a fatty diet is really, really the telltale signs. Now, I briefly mentioned I would say like the reason why gallstones occur. There are 2 reasons. So we have the 2 pictures here, and you can tell by looking at them grossly what's the reason this patient has their gallstones. I will tell you in a surgery, if you get to cut open the gallbladder and take a look at the stones, the reason they have the stones isn't so prudent for the surgeon. It's just cool to see. But for a medical standpoint, yes, or for a learning standpoint, it's important to know why. So on our left here, these yellow stones that we see, can anyone guess what these stones might be caused by? So I'll give you the option. I'll give you the 2 options. So these will either be caused by cholesterol, or they'll be caused by bilirubin. So the one on the left, what do you think it's caused by? Good, cholesterol. Yeah. So that one on the left is definitely caused by cholesterol. You can see that it's a yellow color. I like to just think of it cholesterol. I think of being fatty, and in the body, the fat layer is yellow. And then on the left here, we have what we call pigment stones. So these are caused typically by someone who has like some sort of hemolytic disease, or an increase in bilirubin because of the lysis of red blood cells, and then you'll get what we call pigment stones. But remember, it doesn't matter what the causes of these stones are, it's still 20% chance that they'll be radio opaque. So no matter what, you'll still do a right upper quadrant ultrasound to view both of them. It's just grossly when you're looking at them is where you'll see that difference. So the diagnosis and evaluation. So I already talked about the right upper quadrant ultrasound. I won't talk about it too much. There are some other tests, I should say, that you do. One is called an MRCP. So this is it's used to see if there's an obstruction in the cystic duct, and it's used only in certain situations. It wouldn't be used in like a typical case for someone that you're just kind of thinking of cholecystitis. They don't have any like alarming symptoms like high temperature, high fever, jaundice. And I misspoke. I said MRCP is for cystic duct obstruction. MRCP is for a common bile duct obstruction. So that's where, if we go back to our little picture here, so that's an obstruction here. So you can see that in our case, we had cystic duct obstruction. So that was here. So the liver still had a way for the hepatic ducts of the liver to drain into the duodenum. However, if we have the obstruction here, we block that route and we block the gallbladder's route. And so this is why you'll start to get jaundice in these patients. And this is a much more severe disease than just having cholecystitis caused by gallstones. And that's what an MRCP will show you. It'll show you if there's anything in that common bile duct. A HIDA scan, it's a nuclear medicine scan, and this will show you if there's anything blocking the cystic duct specifically. Again, depending on the patient, if we had high suspicion that this patient had a common bile duct obstruction, and things that will tell us that, like I mentioned earlier, would be jaundice, high fever, they'll have signs of cholangitis, but then also On ultrasound, you'd be able to see if there's common bile duct dilation. So if you have a dilated common bile duct, that tells us that maybe something either passed through there that caused it to dilate, or there's something currently stuck there. And you may not see it on an ultrasound. So that's where the MRCP would come in handy to see, is there something in our common bile duct? And if there isn't, then we can do a HIDA scan to see, is the gallbladder actually blocked or not? And we can use the HIDA scan in the case of, let's say we have a very, very sick patient who we don't think is a candidate for surgery in the moment right now. However, if they have an active obstruction in their cystic duct, it still needs to be treated some way, right? However, stones that get stuck in the cystic duct don't always have to stay there. Because remember what I said, when we eat, that CCK enzyme will cause this to contract. And if there's a stone, let's say that's stuck right here, sure, it might be stuck there for maybe a day or two, and then the gallbladder is contracting against it. Maybe one day the pressure of the gallbladder will cause it to actually go into the common bile duct and get into the intestines, and the patient will pass it on its own. In that situation, you don't need to take a high-risk patient to the OR. So high risk meaning they have multiple comorbidities, they're acutely ill, they have some other underlying illness that's not due to the gallbladder, and that's why they're a high risk patient to take to the OR. So you do a HIDA scan to see, is there actively an obstruction there? And if there is, you have some options that you can do. So we've already talked about cholecystectomy. That's your go-to for anyone who is a surgical candidate. If they're not, what you can do is you can do something called cholecystotomy tubes. So what this is what they'll be doing is they'll be placing tubes into the gallbladder that'll come out of the patient's abdomen. And so that you won't start to get this buildup of bile here that will cause the pain and that will cause the infection. And so there's this a program that I use or lectures that I've used that basically say, think of, if you're thinking of why something can be infected, if it has a lumen and you block the lumen, you're going to block everything coming out of there. And so that blockage and the increase of contents in, let's say, like our gallbladder for the bile is going to cause there to be an infection. So if we have a way to remove the bile so that it's not inflamed, it's not infected, it's not constantly distended, then we can decrease the risk of it becoming infected. And that's what a cholecystotomy tube does. That'll actually, the patient will have like a bag, like if anyone's seen like a colostomy bag, similar. Obviously, it's in a different area. It's draining only bile. It's not draining any stool or anything like that. And the patient will empty it, put a new bag on, and so forth. The other thing is that if someone's coming in and they're not a candidate and they're specifically having gallstones, recurrent gallstones, but let's say they don't want to have the surgery or they're not a candidate for the surgery, instead of doing a cholecystotomy tube, you could try ursodiol. So this is a medication that's given that, easiest way to think of it right now for you guys is it softens up the stones and it also prevents new stones from occurring. And so softening up the stones will hopefully let the body kind of break it down and pass it through on its own. And then it prevents new stones from occurring as well. So what's next for you guys? Before I do that, does anyone have questions on what we went over? I know it was probably a lot. Hopefully you guys found it interesting. Any questions whatsoever right now about the session, about med school, about surgery, anything? All right, so what you guys have to do going forward. So on that SOAP note, if you continue on after filling everything out, there's a 10-question quiz. Fill it out to the best of your ability, as best as you can. I made a point to talk about every question that we kind of is listed there throughout the PowerPoint. When you score above an 80 on that, you'll get a certificate of completion, and that can be used when you're doing applications and so forth. And then some of the upcoming sessions for you guys to kind of know and keep on your radar. We have Emma, she's going to be talking about anemia, Emma F. Emma I is going to be doing a cardiac arrest specific to emergency medicine. And then Dr. Banks is doing a cardiology lecture on bacterial endocarditis. So does anyone have any questions before we end? I feel like there was one question that I said we'd go back to that I never did. So there was a question, I believe it was about the appendix and having umbilical pain or pain around the belly button for appendicitis. So just so you guys know, appendicitis, it classically starts with umbilical pain, and then later, as the disease progresses, it gets to be more localized right lower quadrant pain. The reason for that is because appendicitis, again, think of it the same way that we've been talking about cholecystitis. It's a lumen. It's like a tube, and the reason we get appendicitis is because that tube gets blocked, and so the appendix becomes inflamed and starts to store things because it can't release it, right? And so what's the first thing that happens is that you get visceral pain because of the nerve innervation of the appendix and the sphincter that's there. If I remember correctly, I think it's like your T8 to L1 maybe, but don't quote me on that. And so that'll typically first present with the umbilical pain. And then as the appendix distends and gets larger and larger, you'll get visceral pain, which is the specific pain that you feel in the right lower quadrant. I feel like that was a question. But yeah, if you guys don't have any other questions about anything, then we are done.